It's that time of year again. Everyone knows that the holidays can become overwhelming quickly, so the sooner that you get things done, the better. For both shoppers and businesses, the best time to score great deals during the holidays is Black Friday and Cyber Monday weekend. And that's why you need Shopify. Shopify is the commerce platform behind millions of businesses around the world and 10% of all e-commerce in the U.S., from household names like Allbirds and Cowboy e-bikes to entrepreneurs who will be participating in their very first Black Friday or Cyber Monday this year. Shopify has everything you need to succeed from start to finish. First, Shopify's marketing tools help push your brand to the forefront of the chaos, no matter what platform your customers are on. Then, Shopify helps draw customers in with the ease of a convenient checkout with Shop Pay, Shopify's expedited checkout that saves customers information and reduces hassle. The best part? Shop Pay has been proven to boost conversions, meaning you see less abandoned carts and more profits. You can also stress less knowing that Shopify's award-winning customer support team is on standby 24/7 to help with any issues that arise, allowing you to get back to business as fast as possible. This Black Friday, join thousands of new entrepreneurs hearing for the first time with Shopify. Sign up for your free trial today at shopify.com/income. That's shopify.com/income. Go to shopify.com/income and make this Black Friday one to remember.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies. And today we're going to geek out about placentas and umbilical cords. So years ago, I did a blog all about the cord around the baby's neck. And what's interesting is that's called a nuchal cord, and it happens in about a third of births. But this particular blog entry really created a lot of reaction. People talked about being scared they were strangling their baby. People were just really overwhelmed by the idea of the cord wrapping itself around the baby. So I wanted to find a guest to come on and help bust that myth and honestly take away some fear. So I have Dr. Jessica Vernon on, and we are just diving into everything placenta and umbilical based. So we talk about the role of the placenta. We talk about common issues that arise like placenta accreta, placenta previa, placental abruption. We talk about low-lying placenta and how it resolves. We really go deep into the whole understanding about the placenta. Then we switch gears and talk about the umbilical cord. What happens if the cord is around the baby's neck? What does that even mean? And then we're also going to go into true knots, cord prolapse, how it's handled, how it's monitored. And then, of course, the funny thing that you probably notice, in most movies, we never talk about what happens after baby's born. So we're going to talk about how does the placenta umbilical cord finally come out? What's the timeline for that? So I'm hoping by hearing this, any fear you have about, oh my gosh, can my baby breathe? Remember, they're not breathing how we breathe. They're not breathing, their lungs aren't inflated, they're not breathing oxygen. It's the amazing umbilical cord and placenta. So I'm hoping this brings you some confidence that our bodies are so smart and they're being well taken care of. So I'm excited for you to hear this conversation. So let me tell you a little bit about my guest. Dr. Jessica Vernon is a board-certified OBGYN who has cared for and supported thousands of people throughout their reproductive journey over the past 15 years. She is the Associate Medical Director and Director of Mental Health at Oula, a midwifery-based women's health startup in New York City. And she's the author of the book, Then Comes Baby. As a mom of two, she brings her lived experience with the transition into parenthood to her work. And Jessica actually came on to the podcast and talked all about her book, Then Comes Baby. So I'll make sure we link all of that in the show notes. It was such a great conversation, both this conversation about her book and about the placenta and the umbilical cord, which I'm really excited for you to hear. Now, before we dive into that conversation, I always love to give some updates about what's happening at the studio. Really, for the most up-to-date schedule and classes, check out our website, prenatalyogacenter.com. There you can check out our workshops, our on-demand workshops, our in-studio workshops, and we have a teacher training. So if you're a yoga teacher and you want to dive into our specific methodology and bring this to your community, check out our 85-hour online and in-person prenatal yoga teacher training. So much is there for you on the website. We have our past podcasts and it's been like 20 years of blogs. So much for you there. And you can also sign up for our newsletter when you're there. All right, I do have a favor to ask you. Can you please leave a rating and review wherever you listen to this podcast from? Please leave that because it helps people find the podcast. This whole thing is a labor of love to help support our community. And the more people that we bring to our community, the more support we can offer them. And then the very last thing is I love hearing the stories back from you, the listeners. I've had people reach out wanting to share their birth stories. So please share if you want to. We have an application to come on the podcast. It's on our website. So if you have your birth story to share, or maybe you're a birth professional, you want to share a bit about what you do, please fill out the application because I love to hear from the community. Okay, that's enough from me. We're going to take a super quick break. When we come back, please enjoy my conversation with Dr. Jessica Vernon.
As a contractor, I don't pay for materials I don't use. So why would I pay for stuff I don't need in my mobile plan? That's why my Biz plan from Verizon Business is so perfect. Now I can choose exactly what I want, and I only pay for what I need.
Right now, with my Biz plan, get our best price, as low as $25 a line. Visit verizon.com/business to get started today. New lines only. Price per month with 5+ lines. Includes auto pay and paper-free billing and promotional discount. Taxes, fees, economic adjustment charge. Applicable add-ons, prices, and terms apply. Guarantee applies to base monthly rate and stated discounts only. Add-on prices additional. Offers in January 5th, 2026.
Hi, Jessica. How are you?
Hi, I'm good. How are you, Deb?
I'm doing great. So as I was saying before I pressed record, I'm such a big geek. This is so exciting to me to talk about placentas and umbilical cords because I've wanted to do this and I had to find the right guest. And so thank you for coming back on the podcast to let me pick your brain. So thank you for your time.
Oh, thank you for having me. I love placentas too. And I get so excited and ask everyone if they want to see their placenta. And some people are like, absolutely not. And some people get really excited like we do. So I'm glad to explain a little bit more about it to your listeners.
A picture of my daughter's placenta still. And yeah, they're fascinating. So, all right, let's jump in. But before we get into our topic, why don't you share a little bit about yourself and what led you to the wonderful world of obstetrics?
Sure. I did not think I would ever go into obstetrics. I thought I'd end up on the other side, like end of life care, but I love having these really vulnerable conversations and experiences with people. And so I think when I did my rotation in obstetrics and I was working with midwives, I was down on the Texas-Mexico border where like the midwives ran labor and delivery and the OBs just came in when they needed to for operative vaginal births or cesarean births. I really got to learn about the art of laboring and determining the position of the baby and helping people through this really intense, pivotal time in their life and seeing people feeling so empowered after they gave birth and so held by their midwife. So I was like, this is amazing. This is such a cool experience. And that took me towards obstetrics. And I've been practicing OBGYN for over a decade in New York now, and I still do a lot of obstetrics, and I work in a collaborative care practice with midwives called Oula. So I'm still with the midwives. I have my midwife heart, even though I'm an OB. And I also do a lot of perinatal mental health work as well now, which is one of my passions. So holistic care and birth equity are two of my big passions, and I focus on that in the care that I give.
I so respect the work you do. And I'll make sure I mention in your bio, you're also an author, but we'll get what your other podcast is about, but just had to throw that bone out there. So, all right. So let's jump into some of the basics about placentas? Because some folks may not have the love for them that you and I do. So what exactly is the role of the placenta and the umbilical cord, and when did they even form during pregnancy?
Yeah, so you can't have a pregnancy without a functioning placenta and umbilical cord. The placenta is an organ that we grow along with the baby. It starts developing really soon after you get pregnant, and it takes over for the corpus luteum, which is the cyst that develops when you ovulate. It takes over producing hormones and supporting the pregnancy at around 10 to 12 weeks of pregnancy. And it is giving the baby all of these rich nutrients, oxygen, hormones, antibodies, everything they need to grow and develop. And it takes away all of the waste products. So it's really an amazing organ.
Isn't it amazing that not only is the body making a person, it also makes this organ that we need to grow the baby. And then when the baby's out, we're like, we don't need that organ anymore. All right, bye. I just think there's something so miraculous about that.
It is. It's really incredible, which is why I love showing people their placentas. I'm like, your body made this too. It didn't just build a whole human being. It also created an organ to support that baby.
That is so cool to me. All right. So what are some of the common issues that arise with the placenta? Like previa is a big one we see, accreta, all the placental issues, abruption. Can you talk about all those?
Sure. And I don't want people to worry because when we say common, we mean these are the most common things that we see with placentas, but they're still not very common in general. So things that we see often, especially earlier on in pregnancy, if you're getting earlier ultrasounds, you might see this on your report more often, that you have a placenta previa or a low-lying placenta. And that's when the placenta is either covering the cervix or within a couple centimeters of the cervix. And that is pretty common and often resolves by the time you get closer to giving birth. We also see placenta accreta spectrum, which is when the placenta starts to grow into the muscular layer of the uterus. Normally it would stay on the endometrial or the decidual layer, which is the internal soft, fluffy layer of the uterus. But if there's any little defects in there, which can happen most commonly if you've had a prior C-section or other surgery inside your uterus, then the placenta can adhere to the muscle layer, which can lead to accreta, or if it grows through that, even more rarely increta or percreta, meaning it grows through the uterus completely.
So what happens with those when someone has that? And then I'm guessing it doesn't detach very easily. What's going to happen when you discover that?
So if someone has an accreta or something along that spectrum, then they're usually transferred to the care of either an obstetrician who's comfortable managing it under the supervision of a high-risk OB doctor or maternal fetal medicine specialist, or just transferred to a maternal fetal medicine practice. Either way, the high-risk OB doctors are going to be monitoring closely to look at how the placenta is developing as it continues to grow, making sure it's not going through the uterus and into any other organs in your pelvis, which is very rare. But even if it just stays as an accreta firmly attached to the uterus, then there's more risks with the birth. The biggest risk is that if you try to detach the placenta and it's very stuck and those vessels are embedded there, then you can have a lot of hemorrhaging. So sometimes you end up actually needing a hysterectomy or removal of the uterus with the placenta at time of delivery.
Wow. Okay. So there's that. And can I circle back to placenta previa for a moment?
Yeah, totally.
All right. So one thing I think folks may not always understand with placenta previa, and I'm sure you can chime in more about this, is that once the placenta adheres to its spot, you can't really move it. The uterus lifts it. But I've had students be like, if I do down dog, is that going to move? And I'm like, no, it's not like a slip and slide. So it's attached, and as the uterus grows, it lifts. But you and I had talked a little bit, and as I mentioned, this came up in a class. Do you happen to know, and I didn't put this in the questions ahead of time, so if you're like, too much, why those that have IVF tend to be more prone to placenta previa?
Yeah, it's a good question. And I think they're still exploring some of the reasons for this. One of the reasons that people who have IVF are more at risk for all sorts of things with the placenta and the cord is also that a lot of people are advanced maternal age or a little bit older when they're getting pregnant. And so that also puts you at a higher risk for things with the placenta and the cord. But as far as implantation, we know that when you're doing IVF, someone is putting that embryo into the uterus as opposed to the egg coming down the fallopian tube, meeting with the sperm and implanting. And so that's thought to have an effect on where the embryo implants. Because we know also with IVF, there's a slightly higher risk of things like ectopic pregnancy. So sometimes the embryo just implants in a place that wouldn't be as likely if it was doing it kind of on its own. It doesn't mean it's bad or wrong. It is totally fine. And it's nothing that you do wrong or that's wrong with the IVF process. It's just when we're growing an embryo in a lab and then we're implanting it, the process is happening a little bit differently than if it was happening spontaneously.
Can I also pick your brain about the advanced maternal age? How does that affect where the placenta adheres? Or is that just placental health?
So with advanced maternal age, we know that there are higher risks of things like accreta and previa. And I don't know exactly why. It's just one of those things. It's an association that we've seen. I haven't seen a lot of data as to the indications. But then when you add that with IVF, you get even a slighter, more chance of these things happening. Yeah.
That is fascinating. All right. So we have one other, I know my jaw's dropping. Like, just talk to me about this. So let's talk a little about placental abruption, what it is, and often, really, how often do you see it?
Right. Placental abruption is also another pretty rare event. The biggest risk factor for it is if you've had a placental abruption in a prior pregnancy. And what this is when the placenta starts to detach from the wall of the uterus. And sometimes it can be a very small abruption. Sometimes people have what we call a chronic abruption, where they're coming in throughout pregnancy with little bits of spotting and light bleeding here and there. But still the baby is looking okay in testing. We're not seeing where they're getting a large amount of bleeding or a big blood clot behind the placenta. And so they might be monitored. Sometimes there's a more severe abruption where more of the placenta detaches, which can be associated with a large bleed and fetal distress where the baby needs to be born right then. And sometimes it happens during the labor process, and depending on how much bleeding there is and how the baby's doing, sometimes we can still get to a vaginal birth. If it's more severe, sometimes we have to go for a cesarean birth. But there's all sorts of different things along this abruption spectrum as well, and how it has to be managed.
All right, so people might be hearing this, and you were really great about saying, well, these are the ones that people might see. They're not super common. So let's talk about how they're even diagnosed and monitored. So that way, if people are like, where's my placenta? What's going on? They understand that for the most part, it's being figured out. So how are they diagnosed and monitored?
So often these are diagnosed for the placenta previa and accreta on an ultrasound. And usually that happens around your 20-week scan when you're getting your comprehensive anatomy scan, where they're looking at all of the structures on the baby. At that point, the sonographer is also taking a close look at your cervix and your placenta and the uterus itself. So you're getting a good idea of what's going on. Often, if they're concerned that there might be a low-lying or a previa, then they'll do a vaginal ultrasound as well, where they can actually see if the placental edge is covering the cervix, and if not, how far away it is to see if it meets criteria. And then if these things are diagnosed, then they will be doing more frequent monitoring to make sure the baby's growing okay, to see if the previa or the low-lying placenta resolves, for the accreta to make sure it's not progressing and growing further into the uterus. Abruptions are rarely things that we're just spontaneously picking up on an ultrasound. You might, in the first trimester, see something called a subchorionic hematoma, which is very common. And that's like a little bleed inside the uterus, usually like a centimeter, maybe a couple of centimeters, as the embryo is burrowing into the endometrium. And that usually resolves on its own and doesn't lead to anything like an abruption. So abruptions are more often we're picking them up because of symptoms of either pain or bleeding.
So one thing I've noticed in my years working with the perinatal community is that there was a shift, and this even happened to me between my two kids, that when I had my son, he's 14 now, so again, it was a while ago, I just had a big 20-week anatomy scan. Then when I had my daughter, and she's 11, I had a 16-week and then a 20-week anatomy scan. And at 16 weeks, I was told I had placenta previa, and I'm like, oh, that's interesting. And then by like 28 weeks, it had resolved itself. But are you noticing, because of these earlier scans, more placenta previa? Like, do you think it was there all the time, but now that we're doing earlier scans, or do you think it's the IVF or a combo of everything?
It could be a combination, but honestly, these earlier scans are really making it more seen. And I think it does a disservice. I mean, I've been at places before where even if you're doing earlier scans, you're not really calling a placenta previa at that point. Because if you see it at 16 weeks, most often it's going to be gone by 20 weeks or so, even if it's covering the cervix completely at that point. But yeah, people are getting very scared because they're getting this diagnosis early. They're told that they have to be more careful about activities. And I even have had patients who are like, the high-risk doctor counseled me that I'm going to need a C-section at 36 to 37 weeks. And this is at 16 weeks of pregnancy. And so, you know, sometimes when we go looking for some things, we find other things that are best left alone and not commented on. But now they're just putting everything in the reports to be thorough. And so often you'll see this. So I'm always reassuring people that it does not mean that it's going to stay.
What's the percentage? Do you know the percentage of it staying? I thought it was like less than 3%, but my number's pretty off.
Yeah, it's pretty low. The ones you see stay most often are ones that are what's called a central previa, where it's kind of right smack over the middle of the cervix. But most of the ones where it's only like the edge, it's like an anterior or in the front or posterior or on the back placenta, and just the edge of it's covering the cervix, then those tend to resolve by the time you get into the third trimester. So yeah, it's a very small percentage that's staying.
We do have some modifications just to err on the side of extra safety in prenatal yoga. Like, we don't do this abdominal toning with them, which puts a little bit of downward pressure. I'm not having them do a lot of things that put a lot of downward pressure, like big squats and stuff. Is there anything that you recommend people steer away? Again, we're not doing like high impact jumping either, you know, so we're prenatal yoga. But is there anything if someone does have previa or low lying that you suggest for your clients or patients not to do?
Yeah, I mean, we're basically recommending pelvic rest because intercourse or any sort of stimulation that can lead to orgasm contractions, that can cause some bleeding, especially if there's a previa. That's going to be more common as you get into the third trimester, when the uterus tends to be able to contract more easily. And then nothing where they're putting a lot of stress or pressure on that cervix. So any sort of exercise, like you're doing modifications with your clients, where you don't want to do anything that's going to put too much pressure. But other than that, normal, day-to-day activities, going to work, walking, light exercise is totally fine. This being said, if you do have a bleed, then there might be further modifications, because we do know that people who have a bleed can have recurrent bleeds, and recurrent bleeds can be more than the previous bleed. So we're extra cautious with those people.
Yeah, that's perfect advice. All right, so we're going to take a break, and we're going to come back, and we're going to switch gears and talk about the umbilical cord. All right, we'll be right back.
Oh, Hilton stay, your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh, Hilton stay.
When you want holiday comfort you can count on, it matters where you stay. Enjoy comfortable rooms and friendly service when you stay with Hilton instead. Save up to 25% this season when you book with Hilton. Hilton for the stay. Terms apply.
REI Co-op presents a perfect outdoor moment with the perfect gift.
Woo!
Picture this. You're ripping with your favorite person. Bluebird skies, blower powder, and frankly, you're skiing like legends.
So sick. Another lap?
Thanks to REI's curation, from lid to sticks, you nailed the gift.
No way. How'd you know?
Does it get more perfect than that? Give without guessing. Shop in store or visit rei.com.
Okay, we are back. All right. So another really fascinating topic. I also think they're really cool looking. So I often hear parents worried about the umbilical cord being around the baby's neck. I actually did a blog about this years ago, and oh my goodness, I think it's probably the most commented on blog. So how common is this? How dangerous is it? How is it resolved? And can we also talk that babies don't actually breathe air through their lungs and their mouth and their throat?
Yes.
So I think that's not always, I think honestly people are like, oh, that's true, but they think they're being strangled.
Yes. Yeah. I can see how that visual would provoke a lot of fear in people. An umbilical cord around the neck is pretty common. About a third of babies have the umbilical cord around their neck at full term. It's a little more likely if they have like a really long cord or they have a lot of fluid where they can do somersaults and all sorts of gymnastics inside and twist themselves up in their cord. But it is very common, and it's very rare that it causes anything of concern during the pregnancy. Most babies are born full term, often still with a vaginal birth. Occasionally, the cord will get very tight when they are laboring or when they're trying to push. And again, it's not that the baby's getting strangulated per se around the neck. It's that blood flow through the cord is getting pinched off. And that's what causes the babies to have some distress if that happens. But most babies with a cord around their neck are able to be born vaginally.
Actually, let's dig into something. I can't believe I didn't even ask this about kind of the basics, because I'm not sure that if everyone understands. And of course, if you haven't studied this, most people might not realize, but the baby, how is the umbilical cord supporting the baby? It's, from the placenta, because that's where I think people are confused maybe about nutrients and air and not air, but like oxygen in the blood. So does that make sense?
So, yeah, totally. So the umbilical cord is bringing oxygenated blood and nutrients from the mom or the birthing person to the baby. And then it also takes away the deoxygenated blood and waste products back through the placenta to be cleaned and filtered out through the birth parent. So it's a really important part of this whole system. And if your placenta is not working well or your cord isn't working well, then that's going to cause complications.
Can you talk also about the cord elasticity? And remind me if I'm correct about this, the thing called Wharton's jelly, is that the thing that helps it stay elasticized? Is that the right word for it?
Wharton's jelly is like this lovely, thick coating around the umbilical cord, and that's what gives it strength and makes it hard for those vessels to be compressed too easily. And this comes up a lot if you have what's called a filamentous cord insertion, where the cord separates the vessels and come out of that jelly before it implants into the placenta. And so then you have these more fragile vessels which aren't coated with this jelly and this nice strong area. And so they are more likely to get compressed. And we watch those especially during labor.
I'm finding this fascinating. Okay, we're going to also talk about I'm like visualizing. I'm going to have to, in our show notes, put pictures of a placenta. Maybe I'll even throw my daughter's placenta in there. And umbilical cords. So let's talk about, I guess, other cord concerns. I know true knots and cord prolapse. That was actually when I was a doula and I was laboring with folks at home. That was always one of my biggest concerns, like when the water broke and we were home. And I'm like, you still feel that baby moving, right? Like all is going okay. So can you talk a little bit about true knots, cord prolapse, and how they're handled?
Sure. True knots are very rare, and that is when an actual knot is formed in the cord. It's more common to have something that kind of might look like it's knotted up, but it's just the vessels are are kind of configured in a way with the blood flow that when you look on the ultrasound, it might look like there's a knot, or when the placenta comes out and you're looking at the umbilical cord, it might look sort of like a knot, but it actually has to be tied into a knot when the baby's doing their gymnastics inside to get a true knot. Again, very rare. It does put you at a little higher risk for the baby not tolerating labor as well if that tightens during labor. But I've seen many people where we didn't even know they had a true knot. And then after the baby's out, like, oh, this is so cool. There's a true knot in the cord, because it is so rare. So
nice snapping pictures.
Not everyone who's giving birth is as excited as I am, but I'm like, you got something special going on here. So those are the true knots. And then the cord prolapse, that is when the umbilical cord comes out through the cervix before the baby's head. And if that happens, that's a true emergency, because if you can imagine, we need that blood flow to get to the baby with the oxygen for the baby to be able to survive. And so if the cord comes down and then the head is pressing on the cord, you're not going to get blood flow. So if there's a cord prolapse, that leads to an immediate emergency cesarean section. And someone is literally from below holding the baby's head up so it doesn't press on the cord, and stays there until the baby is delivered from above. So with the cord prolapse, that is more common if someone has a lot of fluid or polyhydramnios, because if you can imagine, you have this really huge bag of fluid, the head might not be as low. And so when the water breaks and this big gush of fluid comes, the cord can come down below. We can also see in preterm births, it can be more common if the water breaks or if the baby's breech or not, and a head down or cephalic presentation when you go into labor and the water breaks, that's more likely for a cord prolapse. Sometimes we can see what's called a funic presentation on the ultrasound. So before your water breaks, before you're in labor and early labor, we can see that the cord is sitting there below the baby's head. Sometimes that will still move out of the way as the head comes down. But if the water breaks when it's below the baby's head, then the cord's going to come down first.
So say, and I don't want, if I start to enter the fear, maybe I'll cut this, but if you've seen that on an ultrasound, what are you instructing someone if their water spontaneously breaks? And again, that's only about 10% of folks that actually have their water break before the onset of labor. But say that happens. Are you instructing them, like, we know the cord's below the head, come right in if your water breaks, we really want to monitor this and check this out?
Yeah, definitely. And the same with people who have polyhydramnios or a lot of fluid around the baby, because they're at risk not only for cord prolapse, but also for abruption. Because if you think of like the rapid decompression of the uterus and how the placenta separates from the uterus is it's kind of sheared off as the uterus contracts down. So if it's contracting down quickly with that decompression, then it can also lead to an abruption. So anyone who has a lot of fluid around the baby, we do recommend coming in as soon as their water breaks. And this is also why your provider might recommend induction around 39 weeks before you go into labor spontaneously on your own, so that we can monitor at the time your water breaks.
So what are the ways that you are monitoring this ahead of time? And how often, I'm kind of throwing something else at you, how often does a completely normal pregnancy turn into like, cord prolapse? Like you're seeing this ahead of time if you're doing ultrasounds, or I guess I'll just throw that out to you. How do you keep an eye on all this?
Yeah, if there's a funic presentation, often it's something that's just intermittent. It's not something that stays there, unless, say, it's happening in conjunction with the placenta is very low lying. The cord ended up inserting on the edge of the placenta. And so those vessels are covering the cervix. Now, if that happens and you have the filamentous insertion where the vessels separated before going into the placenta, then that's what we call a vasa previa. And that's a more high risk situation because those vessels are holding baby's blood, not mom's blood. So those people are typically in the hospital from 32 to 34 weeks. And then they're delivered between 35 and 37 weeks because you really don't want them to go into labor or their water to break. You can lose very little bits of baby's blood before they don't have enough blood. But that is a very extremely rare situation. So going back to people who have a cord around the neck or have a funic presentation, if it's not associated with anything else, we wouldn't be doing any more monitoring. You'd want to know if they went into labor with a funic presentation. But again, often it's not something that you're really commenting on or seeing in the ultrasounds ahead of time. The true knots, if you notice that on ultrasound, then you would be monitoring the baby during pregnancy a little bit more just to make sure it's not getting tighter and restricting blood flow to the baby.
My daughter had the nuchal cord around the neck, and the midwife was like, "Oh, there's the cord." And she said she kind of somersaulted her out of the cord. Clearly, I didn't see what happened, but I thought it was really cool. All right, so let's talk. I'm like, she just kind of, and she's into gymnastics now, so maybe from birth she was destined for that. All right, so when I was thinking about talking about the placenta and umbilical cord, I brought that up to my husband, and he's actually the one who, because he knows all this birth stuff, he's like, "It's funny, you actually never see that in movies. Like all of a sudden a baby's born, like, yay, the baby's born." And they never actually talk about what happened. Like there's never a placenta delivery. I'm sure as an OB, you probably notice that all the time. You're like, what happened at the third stage? So because that maybe not even that known, will you share a little bit about what actually happens once the baby's out? Because there's more, like the placenta and umbilical still in there.
Yes. I'm so glad you brought this up. And I actually have a chapter in my book about what happens after the baby's born, because people are like, what are you still doing down there? And there's a lot of stuff still going on after the baby's born. So once the baby's born, you enter what's called the third stage of labor. And that is from the time the baby's born until the placenta is birthed. We typically give that stage about 30 minutes. And often before that 30 minutes is up, we'll see signs that the placenta is separating on its own. And some providers will more actively massage the uterus and put tension on the umbilical cord to try to get the placenta out quicker. But you can always tell them to like hold off on that, especially if you don't have an epidural. That's going to be really uncomfortable. And also I like to bring this up because if you have a marginal cord insertion or a filamentous cord insertion, they should not be pulling on the cord actively, because that can risk the cord evulsing or pulling off of the placenta. And then they have to go in with their hand to manually remove the placenta, which is not comfortable either. So all of that being said, within 30 minutes of giving birth to your baby, you anticipate the placenta will come out. And if the placenta has not come out in that time, then that's a delayed separation. And sometimes there might be a cause for that. Sometimes the placenta has just like not fully made its way out. So at that time, the provider usually does a little more investigating as to what's going on.
Let's also talk about, and this, I'm so curious your thoughts on this. So the first birth I started to attend when I was a doula was over 20 years ago. And it was not customary at that time to always give a shot of Pitocin, but that's changed. So I'm assuming that is because you want the uterus to continue to contract to release the placenta. Is that still, it seems to be common practice here in New York. What are your thoughts on that?
It is routine and protocol in most hospitals to give an infusion of Pitocin through the IV post-birth. You can also, if you don't have access to that, in some places will do an intramuscular injection of Pitocin after birth. And it used to be more like after the baby's out and after the placenta's out, you would start the Pitocin. Now, often, like because newer studies and protocols have changed, some providers, as soon as the baby's head out, when they're delivering the shoulders, will start Pitocin. So I tend to wait until after the placenta is out to start Pitocin, because sometimes the uterus contracts down really firmly, and then it's just hard for the placenta to come out if it's getting like, compressed too much. And sometimes you're like, oh, it's just sitting in the uterus, but it can't make its way out. So, but everyone has like different philosophies and ideas around that. If you are low risk for hemorrhage, like you haven't had a really long labor, this isn't your fifth baby, you don't have fibroids, you didn't have a really big baby, all of those things that can put you at increased risk, then you can always defer the Pitocin no one can force you to get Pitocin.
Interesting. Yeah, I guess if your uterus is really tired, it might need that little extra help to stop those blood vessels. So that
Yeah,
makes
yeah.
sense. All
Yeah,
right,
I always tell people if they're, sorry. I always
no,
tell
please.
people, that if they've been in labor for a long time, their uterus is really working hard and it's a muscle. So if you can imagine after a long workout, you're just like, oh, I'm so exhausted. You just want to relax. Your uterus can do that too. So whether you've been
peace
laboring
out,
for
I'm
a long
done.
time, or pushing, or if you've been pushing for a long time, or there's been a big baby that's been stretching it out a lot, like it can just be tired when it's done the work of getting the baby and the placenta out.
That makes a lot of sense. All right. So what are some of the red flags during the third stage of labor that might require immediate medical attention? I think we were kind of talking about one, like your uterus is not contracting and it needs to so that you don't, hemorrhage.
Yeah. And the uterus, if the baby's out and you start bleeding before the placenta has separated completely, then that's sometime when the provider might need to actively manage and try more actively to get the placenta to separate, or even put their hand inside the uterus and separate the placenta from the uterus to stop the bleeding. Because if the placenta starts to separate but doesn't completely, then you're going to get bleeding behind that area and it can't clamp down around that wound that's inside the uterus where the placenta was growing. If you have a cord avulsion or somebody's pulling on the cord and it tears off from the placenta, then that's something also where it's not so common, but I've definitely seen it because some people are pretty aggressive with pulling on the cord. And also if they're pulling on a cord when it's like that marginal insertion or filamentous insertion where it's not as firmly attached to like the center plate of the placenta, then that's more likely to tear off. So I always tell my patients when I see them in pregnancy, like whoever delivers you, make sure they know about this and they're not, being aggressive. There's something called a uterine inversion, which is also extremely rare. I've only seen it once in 15 years. And that is when they're pulling on the cord and not just the placenta, but the whole uterus turns inside out and comes outward. And that is also an emergency where they often need to give something to relax the uterus. And you literally take your hand and push the placenta and the uterus back into where it belongs before separating the placenta. Yeah. Yeah, it's, and I've only seen it in someone who had way more than 5 babies, but her uterus was very tired, and I'm sure the whole pelvic floor was very relaxed. So
this is me getting geeky about
uncommon.
That.
Yeah,
if it happens and they pull the uterus out, I'm guessing they're very much overstretching some of the uterine ligaments. Is that just like immediately giving that person like a uterine prolapse? Are they going to have a successful uterus staying in place? Is that going to need a hysterectomy, or it's a lot of pelvic floor? I don't know if even physical therapy, like you overstretch those ligaments. What happens?
Right. I think it's kind of vice versa, where the ligaments were already probably overstretched and relaxed before. Otherwise, there's no way that uterus would come inside out, But yeah, it's a very rare thing. And I only saw it once when I was in my residency and have not seen it since.
Okay, I'm going to switch gears and start talking about cord clamping. There was a time when I had a lot of representatives trying to do conversations or workshops about cord banking and a conversation about cord clamping. What are your thoughts on all of that?
Cord banking was pretty popular for a little while, and I haven't seen it as commonly anymore. I think a lot of the purported benefits were more like an investment in the future. They think this is where cord banking is going to go and the benefits it will have, but we haven't seen some of that play out. The main benefit that it can have is if you have another baby with a condition, then perhaps they're matches, and this can benefit the other baby. But I think if you're going to do cord banking, it's actually some hospitals, not in New York, but a lot of places that I've been before have have banks that you can donate to, so that if any baby needs cord blood, then they have that available, which is great. So they can find matches for babies who have certain conditions where they might need cord blood. As far as delayed cord clamping, that is very common now. It has shown benefits for both preterm and term babies. The biggest benefit is in preterm babies, where it can really help with their circulation, getting them enough red blood cell volume, decreased transfusions. Also, preterm babies are at increased risk for something in their intestines called necrotizing enterocolitis, which can be really severe, and this can lower the risk of necrotizing enterocolitis, and also getting a bleed in their brain when they're little. It can decrease the risk of that. So for preterm babies, it's excellent. Even for term babies, it is helping increase their hemoglobin, their iron stores, which can really be helpful. And the American College of OBGYN recommends to wait 30 seconds to a minute for delayed clamping. Some people would like to wait until the cord stops pulsating, and that's totally fine as well, as long as mom's stable and baby's stable. Sometimes you need to clamp and cut sooner if the baby needs to be evaluated by the pediatricians, or mom is having bleeding and we need to see what's going on.
But 30 seconds to a minute, that's not very much, considering baby just got out and we have to, bring baby to the parent's chest.
Right.
That's not even asking that much. I love hearing the support behind that. Okay, we're going to take another break. And when we come back, what is one final tip or piece of advice you'd like to offer new and expectant parents? We'll be right back.
This episode is brought to you by Ulta Beauty. Holiday cheer is here, and Ulta Beauty has gifts for everyone on your list. Treat them to fan-favorite gift sets from Charlotte Tilbury and Peach and Lily. Go all out with timeless fragrances from YSL, Ariana Grande, and Carolina Herrera. And you can never go wrong with an Ulta Beauty gift card. Head to Ulta Beauty for gifts that make the holidays brighter and even more beautiful. Ulta Beauty. Gifting happens here.
Okay, we are back. So you wear many hats. You are an author, you are a mom, you're obviously an OBGYN. I would love to hear your final tip or piece of advice you'd like to offer new and expectant parents.
I would say, related to these issues that we've discussed today with the placenta and the umbilical cord, or anything else that comes up that you weren't anticipating during pregnancy, just make sure that you know that none of it is your fault. It's nothing you did wrong. It's not a failure of your body. This is just part of the process, and things can happen along the way. And just make sure you're under the right care of professionals who are comfortable counseling you and managing these conditions, because if you get the right care you need, no matter what's going on, you will do well during your pregnancy and give your baby the best chance for them to thrive as well. So that's the biggest tip that I would give people.
That is fantastic. All right. Where can people find your work? And please mention your book.
Sure. So I am at Oula. You can find me on their website. I'm also at Instagram at Dr. Jessica Vernon, and my website, drjessicavernon.com. My book, Then Comes Baby, is available anywhere you buy your books.
That is fantastic. And I'm not actually sure which podcast episode we'll put first, but there is a whole podcast all about your book and your expertise in that, in how you wrote it. And it was really, really fantastic. So whichever comes out first, we'll make sure we have cross links to the different podcasts. Thank you again for coming on and sharing your wisdom and just geeking out with me. I find this stuff so fascinating. So thank you.
We could have talked so much longer on placentas and umbilical cords. There's just so much.
I actually had to really limit my questions. I'm like, Deb.
I know. If people have other questions, they can always DM me or reach out to you, and we can connect and further offer them some advice. But yeah, if you have any questions, please don't go Google it, because you will go down some crazy rabbit holes. Please reach out to us or your provider.
Thank you, Jessica. So great talking to you.
Great to talk to you as well.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.
Ever wonder whether Stoicism is actually as terrible as all those red-pilled bros on TikTok make it seem? I'm Tanner Campbell, American philosopher of Stoicism and host of the Practical Stoicism podcast, and I'm here to tell you that, thankfully, those bros couldn't tell the difference between their you-know-whats and a hole in the ground, let alone teach anyone anything about any proper philosophy. Stoicism is an ancient Greek virtue ethics philosophy all about developing a morally just character, and you can learn more about it by listening to my podcast, Practical Stoicism. Search for it today in your podcast player of choice and give it a go. I'm certain you'll find it, at the very least, informative.